Hi, good morning, everyone. Welcome to our Unit 2 discussion here in ST115. Hopefully this goes smoothly for us. I've had a little technical difficulties on my end this morning, so um, hopefully it does. Bear with me if it doesn't. All right, so let's jump into this and see what we're going to get into today. Here are your Unit 2 assignments that are going to be due by Sunday. Again, remember your discussion post, your first discussion post is due on Wednesday. And this week we're going to be talking about surgical conscience. And then you do need to go back and respond to a peer by Sunday. So that's probably one thing that I take the most points off for these, excuse me, is people forget to go back and respond to a peer. And that can add up over time, it gets unnecessary points taken off. So just make sure you go back and do those things. All right, so we're going to be talking about today different roles and responsibilities of the surgical technologist, really highlighting what surgical conscience means, especially in your role as a surgical technologist. Talk a little bit about hand washing techniques and different types of sterile technique as well, asepsis and sterile technique. So that kind of leads us to our first question here. How do I know what I can touch in surgery? I think it's probably safe to say that many of you may not, and this is kind of judging by your first intro discussion post, that you've not stepped foot in an OR, which is normal for a student, right? Unless you already have a job in the hospital, maybe you're already working in sterile processing. A lot of people haven't gone into the OR, at least not consciously, maybe as a patient, right? But how do you know what you can touch? I think it's a common misconception for students that everything inside the operating room is sterile, which is not. Um, there's a fine, well, I should say there's a definite line between what's sterile and what isn't. I even talking with my own family, trying to tell them what I do for a living, my dad even said, well, I thought everything in there was sterile. How do you touch things, right? So it is kind of a common misconception, and it is tricky. So to understand what you can and can't touch, you have to know these terms. Okay, you have these three terms that are pertaining to what we call sterile technique, which is what you will practice every single day as a surgical technologist. Sterile technique, what you do to maintain sterility. So what is sterility? Okay, it's this term right here in the middle. Sterile means the absence of all living microorganisms, including spores. That's the kicker, including spores. Now, if spores haven't been killed in the sterilization process, it is not considered sterile. So if we're, working on a patient, we've made incisions, going inside the patient like that, we have to have things that are sterile to prevent infections. Everything we do as surgical technologists our goal is to prevent infections for that patient. We don't want them to get an infection from surgery when they're already probably immunocompromised or they have other things going on. We don't want to make it worse for them, right? So this term asepsis, if you know your med term, this prefix A at the beginning means without, right? Sepsis is referring to like an infection. So asepsis, the practice of keeping things sterile, which is the techniques that we use to do that, our aseptic technique. It's kind of the same thing as sterile technique, same concept. And then this term contaminated over here means the presence of living organisms. So contaminated and sterile are opposites. So if something is not sterile, it is contaminated. There is no gray area with sterility. Something cannot be sort of sterile or kind of sterile. Either it's sterile or it is not. So you will hear us say a lot of times in surgery, when in doubt, throw it out. If there's ever any doubt whether or not something is sterile, you throw it away. That's never a question, right? Because if you have to question it, the odds are it's probably contaminated and you shouldn't be using it on that patient. So if it's contaminated, either it didn't go through the contamination process, or maybe while we were draping, let's say, something not sterile touched the sterile item, that renders that not sterile or contaminated. So those are the basic vocab terms, I guess you could say, to start this conversation. So along with that, what would we consider the sterile field? If not everything inside the OR is sterile, what would be our sterile field? What do we work from in surgery? So this would be you, let's say, all right? You are going to be one of the sterile team members in surgery. You have to wear a sterile gown and gloves. So that means these items have been put through a sterilizer to render them without any microorganisms, including spores. Okay. So you can't go touching things that haven't gone through that sterilization process, or you become contaminated. Okay. So the sterile gown, this is a surgical sterile gown with sterile surgical gloves. These are not the same as your exam gloves. They're not the same. Exam gloves are not sterile, the ones that are just on the wall. So the gown is considered sterile from the fingertips of the glove to about 2 inches above the elbow, around mid-chest to lateral, not around the back though, near the umbilicus or belly button. So it is not sterile everywhere else. So that means your shoulders of the gown are not considered sterile. Your neckline, below here near your knees, the backside that you cannot see, those are not sterile areas of the gown. So you cannot be touching them with your sterile gloves. So even though your shoulder may itch up here, your neck or whatever, you can't go up here and scratch it. So kind of, it's a lot of discipline sometimes when you have those itches and you can't touch them because you're sterile. So keep that in mind, okay? So another part of the sterile field is the sterile back table. So the table, once this drape has been opened onto it, is only sterile from the table top only. So this light blue part that's hanging down is not sterile. Tabletop only. So when you go to move this table, you cannot grab underneath the table, like cup your hands under and pull. You have to keep your hands on top, flat, to move this table, but it is on wheels, so it's not too bad. And then when we open sterile items that have gone through a sterilizer, they're wrapped a specific way so that we can open them without contaminating them. Okay, so the unsterile person, let's say your circulator, is going to open these sterile items. If they're unsterile, they open it away from them first, which keeps this part protected. So this flap for this got opened first, and then side to side, and then this flap gets open last. So this is pertaining to a non-sterile person. And I'll tell you, this little sequence right here is on a lot of certification exams. Put the order of opening a sterile item, if you are not sterile, in the correct order. They want to make sure you understand that this flap has to be opened last because it protects the item from your not sterile self. So you can see that this person is holding this drape right on the edge, okay? So this drape is not sterile along about this 1 to 2 inch border along the outside. So everything from 2 inches inward, where that item is wrapped, is sterile. But where they've touched along this outer 2 inch border is not sterile. So keep that in mind when you, as a sterile person, come over here to grab this item. Don't touch that edge. Okay, so now that we know what the sterile field is, how do we maintain it? How do we keep things from getting contaminated? Okay, this right here is one of the most important things you will do as a surge tech. That is your main job, is to maintain the sterile field. You have to maintain sterility and understand and recognize when that sterility has been broken. And this is not just pertaining to you, right? You have to obviously recognize if you mess up or make a mistake, but you also have to recognize when anybody else in the room contaminates your field. So that might include calling out a doctor when they've contaminated their glove, let's say. If they accidentally go up to grab the light handle to move it so they can see, but maybe their glove touched the actual light and not the sterile light handle. And you recognize that, you see that. It's up to you to say something to that surgeon. Maybe they weren't looking when they did it and didn't see. That happens, okay? It's not that you're calling them out to, make a scene or anything like that. You're protecting the patient. We say we are the patient's advocate. We're there to advocate for them because they can't speak for themselves if they're under anesthesia. So that's our job. We want to make sure they stay safe. So you have to have eyes everywhere. You are watching everybody, not just yourself. So it takes some time, it takes some practice. It takes a little bit of, I would say, courage, especially for students, to have the, what's the word, to have the gall, I guess you could say, to speak up for themselves, the courage, really, to speak up to a surgeon that is probably intimidating and say, hey, you contaminated yourself. But I'll tell you, sometimes surgeons or maybe your preceptors even are looking to see if you recognize those things. Do you call these things out? Um, because they're watching you to see what you know. Okay. As a student, you're there as like a job interview. So they want to see if you're recognizing breaks in sterility and if you're willing to speak up for those things. So don't be afraid to just calmly state what has happened and then we'll correct it. It happens. It's not the end of the world. Okay. Along with maintaining the sterile field, a couple more terms, I guess you could say, strike-through contamination and SSI. So we're talking about strike-through contamination. We are referring to fluid that has gone from a non-sterile side of the drape, usually the underside, that has gone through or like soaked through that drape to the top sterile side, causing it to become contaminated. Now, most of the drapes we use, like that we cover the patient with that you've seen, or that blue drape I put on the table, even your gown, those are supposed to be what we call impervious. Impervious, which means fluid should not be able to go through that. It is meant to prevent strike-through contamination. Every now and then, maybe there's an excess amount of fluid that overwhelms it. Maybe there's a hole in the drape, right? If fluid can come from a non-sterile side to a sterile side, that is strike-through contamination, and now it's contaminated. So ideally, you would get rid of whatever is contaminated and get a new one. If there is strike-through, if there's contamination and you leave it, you could lead to something called an SSI in that patient. SSI stands for surgical site infection. This is what we don't want for our patients, right? Here's a gross one. It's a nice picture right there. This is a surgical site infection. Maybe the incision got, maybe it just wasn't cleaned right. Maybe it was trauma. A lot of traumas end up with surgical site infections. Maybe there was a branch sticking through his leg. Who knows, honestly. But the bacteria that most likely causes SSIs, and I would memorize this, is Staphylococcus aureus. Staphylococcus aureus, because that is often a certification question. Okay. We have Staph aureus living on our skin normally. So it's considered part of our normal skin microbiome. It's a resident flora. So even though we prep the patient with, let's say, betadine or chlorhexidine, whatever, we cannot get rid of all bacteria on the skin. It's impossible. You cannot sterilize living tissue, such as skin. So we are trying to reduce this bacteria particularly, there's several others, to what we call an irreducible minimum. We're trying to get those as low as possible to prevent something like this, because as soon as we make an incision, that bacteria can now travel deeper in the tissue and then cause an infection because it's considered opportunistic. Usually it doesn't cause a problem living on the skin when it's fine, no breaks in the skin. As soon as we open that tissue, now it's opportunistic. It has the ability to thrive in a different environment. We try to reduce those with our techniques. Okay, moving on to the basic hand wash, which also is going to be important in preventing infections. One of the most, actually, has been scientifically proven the most important tool for preventing infections, good hand washing. So we consider hand washing event related. You need to wash your hands at certain times, at certain events, right? So when your hands are obviously visibly soiled, you have to wash them. If you come back from obviously the bathroom, you wash your hands, right? After you eat, when you first enter the OR, first thing in the morning, really you should do a basic hand wash before you do anything else, even before you do your regular scrub, okay? So it is event related. It takes about 30 seconds, so a lot of people slack on this. I mean, washing your hands is something we've hopefully been doing since we were kids, right? Little kids. But 30 seconds A lot of people kind of slack on that, right? So you wet your arms 2 inches above the wrist. This is not the one that goes all the way up to your elbow. That's the surgical scrub. This one, you're just going up just above the wrist there. Using your antiseptic, cover the whole surface of your hands, weave them back and forth, kind of maybe even dig your nails into your palms back and forth. You're going to rinse with the fingers down. This is different than your surgical scrub. When we are rinsing for our surgical scrub, we want our fingers pointed up and all the water running down away from our fingers, which are going to be closest to the patient. So this is a little bit different. You're going to rinse with the fingers down and then dry with paper towels in this case. So there is a quick little video, just throwing this out here just as a reminder. Also, I would encourage you to check out this YouTube channel, Surgical Counts. He's got a lot of great videos. I like to add some of these every now and then just to reference. He's a good guy.
So let's review a basic hand wash. Now, a basic hand wash, you're going to do several times in the day, like after you eat, after you go to the bathroom, when you first walk in during the day. The purpose of the basic hand wash is to clean off as many transitory microbes as you can, to get your hands, pretty clean. That's the goal. It's not going to be sterile, obviously, but it's going to be pretty clean, at least safe enough to use in the hospital. Now, the first thing you're going to do is you're going to inspect your hands and check to make sure that there are no cuts or abrasions or anything like that. And right now, mine look okay. So the next thing I'm going to do, I'm going to wet my hands like that. Go up to the wrists and past the wrists. I'm going to get some soap and rub the soap in. Okay? See, normally people will wash their hands like this, and then they're done. But no, what we want you to do is we want you to get in between your fingers. So you're going to get in between your fingers like this. We want to rub the back of your hands like this, down around the wrists, right? The back of this hand, and down around the wrist, like that. Between the fingers, get all those webbing areas, all right? You're going to soak that up real good, and you're going to do this for about 15 seconds. So in other words, the way to remember 15 seconds is sing happy birthday to yourself. So happy birthday to me, happy birthday to me, happy birthday dear Mark, happy birthday to me. Now if you want to make sure, I don't know, maybe I sung that a little fast, but you can also sort of rub your fingernails, get under there a little bit, maybe clean out, check under the fingernails to make sure you don't have anything under there. And when you're ready to rinse, you're going to rinse from your wrists down to your fingers. So the water is going to drain this way. This is going to be different from what we're going to do in a minute, but right now we're going to rinse this way. So I'm going to put my fingers in here and rinse with my fingers pointing down. I can rub them in order to get all the soap off, but the fingers remain pointing down. Pull my hands out, I can turn the water off, and I can go and dry my hands. Dry my hands, and then I can throw them away. And that's a basic hand wash.
So hopefully that's just a good little review for you. Now you can say you can wash your hands, right? I can get my thing to go. Oh yeah. I'm struggling. Okay. So let's move on to the surgical patient. Obviously this is really why we're here. This is why surg techs do what they do. It's for the patient. And if you can remember that every day you go to work, that you're there for the patient, everything else falls into place. The workplace drama, surgeons' attitudes, don't let that get to you. You're there for the patient. Remember that, okay? If that patient is fully reliant on everybody in that room because they cannot speak for themselves, right? So what I always tell my students is every time a new patient comes in that room, you need to think about what if that were your most loved person laying on that table? Maybe that's your spouse or your child, your grandma, whoever it is. I know that kind of may seem a little morbid, but it really puts things into perspective. How would you want your most loved person to be treated? Would you want someone to turn a blind eye to something that was contaminated and just keep going because they're too lazy to fix it? No, you wouldn't, right? You want the best care for those people in your life. So you need to make sure you're providing that for every patient, okay? So keep that in mind as we, go through this course and as you start your clinicals. So along with our patient, we have to talk about the Maslow's hierarchy of needs. So this psychologist, I think, I don't know, one or the other, Maslow has created this nice little pyramid of things that people need, right? So we start at the bottom of the pyramid and work our way up. What's important to remember about the hierarchy of needs is that it is not you climb this imaginary ladder and you're done. That's not what this is referring to. This is a fluid thing. This can change on a daily basis, a minute basis, yearly, whatever. You can refer to it in a lot of ways. But if you look at the bottom, the very basic needs you have to survive: food, water, making sure you're warm, and you have, you know, some sleep, or you won't survive, right? Those are physiologic needs. So our patients, when they come to us, we have to meet these needs for them, right? We have to make sure that they have fluids. Maybe we start an IV. We have to keep them warm so they don't become hypothermic. Rest, that's tricky in a hospital, right? We provide them nutrients. Okay, once we do those things, we can meet their safety needs as well. We want to keep our patients safe. We don't want them falling out of bed or accidentally hurting themselves with maybe a scope that's too hot and burning them. So we keep them safe as well. So these bottom two of Maslow's hierarchy of needs are the two that we in surgery deal with the most: physiologic and safety. Now, yes, we can have some psychological effect on them in the short time that they may be awake. A lot of our patients are put under general, not always, but you can, once they enter the room, start a conversation with them, make them feel at ease, introduce yourself. You're obviously not going to build a lifelong relationship probably, but you can kind of put their mind at ease a little bit, okay? We're not going to have a whole lot to do with their sense of accomplishment or their self-actualization, but once, essentially once these needs are met, these needs can be met as well. That's what this is referring to. Okay, along with other patients' needs, we need to also consider their pain management. If they're fearful, we try to address that, comfort them, calm them. Different age groups require different things. So you're not going to treat a child the same way that you would treat, a 50-year-old man. They have different needs. So it's important to understand each demographic of patient and how you can communicate with them effectively. You would communicate with a child differently than you would with an adult, typically, right? And be very careful with geriatric patients that you don't treat them like a child, because that seems to be a common misconception. For some reason, we try to talk to, 70, 80, 90-year-olds like they're children. They don't understand what's happening. Now, there are instances in which maybe they have dementia and you have to be very simple with them, but that doesn't mean you treat them like a child. So be careful with your words and how you say things to patients, okay? Supportive communication. Again, we don't get to communicate as search techs very often with our patient, but we can be supportive when they briefly come in the room and, introduce ourselves. Always be respectful and be concerned with their privacy. Okay, so that's just a quick little overview of the patient and how we can implement sterile techniques, sterile conscience into our everyday practice as surgical technologists. So keep those words in mind and those concepts in mind as you move forward, because those never go away. All right, you will always have to keep that in your daily practice. So if you have any questions, please feel free to reach out to me. Here's my email. I do have office hours today from 12 to 2. I'm on the East Coast, so I know that I try to make it a little bit in the afternoon, so it's hopefully not too early for the West Coast people. But if that doesn't work, we can work something out. But just shoot me an email and I can get back with you. But so far, you guys are doing a really good job. So keep up the good work.